Well, welcome everybody to our lecture today on HCC entitled Hepatic HCC Education and Protocols to Advance Treatment Through Integrated Collaboration. My name is Adam Burgoyne. I'm an associate professor of medicine in the Division of Hematology and Oncology at UC San Diego in La Jolla, California.
And I'm Stacey Stein, an associate professor of medicine at the Yale Cancer Center.
Our learning objectives for today are to apply strategies for early and accurate diagnosis of HCC stages, to summarize the mechanism of action and clinical profiles of new and emerging IO agents, monotherapy or combination therapy for each stage of HCC, and to describe the role of the HCC care team members and explain techniques to increase communication and collaboration. We thought it would be nice to start with a case today. So this is Elena. She's a 49-year-old Latina woman. She has a history of obesity, hypertension, hyperlipidemia, and she's coming into the emergency room with severe abdominal pain in the right upper quadrant, and that's been progressing over the past several months. So imaging was obtained in the emergency room, which was an abdominal ultrasound to start, and that ultrasound showed an enlarged cirrhotic appearing liver, and there was suggestion of thrombus in the portal vein. So the ER physician ordered some follow-up scans, a CT scan of the abdomen with portal venous contrast, and that scan noted a filling defect in the main portal vein and a hazy mass in the right lobe of the liver that was concerning for malignancy. So the ER physician started her on anticoagulation with a heparin drip and recommended admission. What further workup would be appropriate at this time? Whenever we're seeing suspicious imaging concerning for a liver mass, particularly in patients that we know have risk factors for the development of primary liver cancers, it's always useful for us to refer to the NCCN guidelines for some suggestions on additional workup that might be appropriate. So here we have a suspicious imaging result, and our next step in this algorithm would be to get some more dedicated imaging. So that here would be what we consider to be multiphasic imaging with either a CAT scan or an MRI. And in this case, we chose to proceed with an MRI. So back to our case, the multiphasic MRI of the abdomen with contrast revealed a 13-centimeter heterogeneous mass, predominantly involving the right lobe of the liver, and there was extension of that tumor into the portal venous system. And in addition to that large mass in the liver extending into the portal vein, there was also an enlarged pericaval lymph node measuring 3.2 by 1.5 centimeters. So the radiologist reports this on the imaging report as a LIRADS TIV, contiguous with a LIRADS 5 mass. And that imaging system would be consistent with the diagnosis of HCC with invasion into the vasculature. I'll pose this question to my colleague, Dr. Stein. Is a biopsy required for diagnostic confirmation here?
So this is such a unique question to HCC because we would never think of diagnosing any other cancer without a biopsy. And yet there is this exception in HCC where if the imaging is very characteristic in the liver, especially triphasic imaging, it is not necessary to get a biopsy to confirm diagnosis. You know, we do now for most cancers routinely do molecular profiling, but not frequently in HCC because we have no targets that are often found that we can use. So, you know, it really is a very unique situation that we don't need a biopsy for this cancer. But I think it also has put the field back of HCC in that we don't have the same tissue banks, you know, that are available in other cancers. Dr. Burgoyne, what do you think?
I agree. It's certainly an evolving pendulum. By the textbooks, we've made a diagnosis of HCC for this woman, so we can use that moving forward for her treatment plan. But yes, it's an area of controversy in the area of molecular profiling. Dr. Stein, what do you think about anticoagulation for this woman with tumor in vein?
Yeah, so we see this frequently. And, you know, often when patients first, if they present this way to the emergency room, they're often started on anticoagulation. But if this is truly tumor thrombus, there really is no role for anticoagulation because this is not a blood clot. You know, sometimes it's more confusing when it is a mixed thrombus or harder to differentiate. But in this case, if it is clearly tumor thrombus, the patient does not need to be anticoagulated.
Exactly. And in our patients with underlying cirrhosis that have alterations of their bleeding and coagulation cascades based upon their liver function. We always want to be mindful of whether anticoagulation is warranted or not. So she asks you, how did this happen to me? We do know a fair amount about HCC risk factors and the epidemiology of liver cancer. And I think it's important to pause here and note that liver cancer really is a global disease. And you can see here that based upon geography, risk factors differ. And that's important as we're thinking about both the global population and how we are looking for therapies, both in the US and across the globe. So the breakdown here, based upon these pie charts, is related to underlying risk factors for liver disease. So we know that most patients with liver cancer do have some background liver disease, often with cirrhosis. That can be from things like chronic viral infections with hepatitis B or hepatitis C, from chronic alcohol use, or a really rising and growing problem here in the United States in particular is the incidence of non-alcoholic steatohepatitis, so fatty liver disease, and the constellation of metabolic syndrome, diabetes, obesity, hypertension, leading to fatty liver, and eventually cirrhosis in the setting of fatty liver, which is also a setup for the development of liver cancer. So that's a growing problem here in the US. In addition to hepatitis C, which has been sort of our leading cause historically, but those rates are expected to improve as antiviral therapies for hepatitis C have really transformed the way that we take care of hepatitis C over the past decade. And then globally, really a leading cause of HCC is chronic hepatitis B infection in many parts of Asia, China, and Southeast Asia. So as we're designing clinical trials and thinking about what therapies we use, it's always important that HCC studies are global and that we're thinking about these various etiologies. So back to our case, what additional staging should be pursued here?
We often think about an MRI for the additional abdominal imaging or CT if MRI is not indicated. To complete the staging, a chest CT without contrast. Some people do order a bone scan, especially if there's evidence of other bone metastasis. They use this frequently in transplant to rule out anyone that has occult metastatic disease. I personally do not order a bone scan on every patient for initial staging unless there's a reason to, and we often are able to see bone metastases on the imaging that we have already received. In terms of labs, besides a CBC and a CMP to look at liver function, we would also obtain a PT INR to look at clotting time, as that plays a role in the Child-Pugh score, which we'll look at in a minute. In addition, AFP. So for this patient, back to our case, the hepatitis serologies are negative, and she denies a significant alcohol history. Her BMI is 40. Hepatology is consulted for further management of cirrhosis, which is thought to be secondary to NASH. CT chest and bone scan have no evidence of metastatic disease, and the AFP is elevated at 65,000. And the patient asks, what is the stage of my cancer? What do I do next? And is my liver working okay? So just to remind everyone, the score that we often assign to grading liver function is the Child-Pugh score. Now, this score was not meant to stratify patients with liver cancer into groups for treatment, but it has become a de facto score that we often use in clinical trial enrollment and gives us a sense of overall what the patient's survival is from their cirrhosis, but not necessarily from the cancer. And just to remind everyone, there are 5 factors that go into the Child-Pugh score: albumin, bilirubin, INR, encephalopathy, and ascites. And so the lowest score is a 5. Patients with a 5 or 6 are in the Child-Pugh A group with well-compensated liver function. Those in the B group have a score of 7 to 9, and those in the C group have a score of 10 to 15. So this patient, has been well compensated. And, when we think about, as we get later into the clinical trial data, right? Just to remind everyone that usually the clinical trials were restricted to enrollment of only patients with Child-Pugh A disease, although we frequently are treating patients with Child-Pugh B disease in the clinic. And we'll get to that later in the discussion about how our treatment decisions might be the same or different depending on the patient's Child-Pugh score. And here is the BCLC staging and treatment algorithm. And this has been, again, not the only staging system available for liver cancer, but has become the de facto one that's often used in discussion of HCC treatment and used as defining patients in different stages for clinical trials. So over on the left, we have the very early stages of potentially curable treatment, curable disease, patients who might be candidates for ablation, resection, and then potentially transplant. Later, we have the patients with intermediate stage that really are the patients who usually are referred to our interventional radiology colleagues for local therapy. So they may have multifocal disease that's not resectable, but still well-compensated liver function. And then later we have the advanced stage patients, which is the group that medical oncology is often focused on. So those might be patients with portal vein invasion, extrahepatic spread, but still relatively well-preserved liver function and a good enough performance status that they would be candidates for systemic therapy. And then all the way on the right, we have the patients where they're not candidates really for other treatments, either because of their performance status or decompensated liver function. It would thought to be not safe and probably not an extension of life to offer systemic therapy, where we're thinking more about supportive care and hospice. And so, Dr. Burgoyne, any comments about our staging system?
No, I think that it's a unique piece of HCC care as well that's a little bit different, that we use this Barcelona system for our staging. And for us, I think as clinicians, it's nice that in addition to the kind of canonical TNM staging we use for other malignancies, that incorporates things like performance status and liver function, which are key components of our decision making for our patients. So let's get back to our case. So medical oncology is consulted, and fortunately, Elena is Child-Pugh A. She has good functional status. She's motivated to pursue palliative systemic therapy, and she's recommended to follow up with medical oncology as an outpatient to discuss treatment options. So what could we offer as first-line therapy here? Let's talk about how things have changed. So there's really been just a dramatic evolution in systemic therapy over the past 5 to 6 years. When Dr. Stein and I were first practicing, we were left with really one FDA-approved medicine for HCC, which was a tyrosine kinase inhibitor called sorafenib. That was approved in 2007, and you can see from this timeline, there was really a dearth in movement in activity for changing the HCC space for about a decade. Since that time, since 2017, 2018 on, we've really had this advent in positive clinical trials, both in the first and second and beyond settings. And this has led to the FDA approval of a number of new agents, which we're going to be talking about some highlights today in the talk. When we think about how we are using systemic therapy in HCC, it's always important to think about how these agents are working from a mechanism of action standpoint. And really, at this point in 2023, we're still targeting two sort of main axes in HCC tumor biology. So immunotherapy has become a mainstay of treatment for HCC, much in the way that it has in many other malignancies in this era of immuno-oncology. So targeting things like the PD-1, PD-L1 axis, as well as targeting CTLA-4 with dual immune checkpoint therapy strategies has made it to the clinic in HCC. And then historically, we know that VEGF signaling and other receptor tyrosine kinase signaling is important in HCC tumor biology. So using monoclonal antibodies that target VEGF, as well as tyrosine kinase inhibitors that target the VEGF receptor, as well as other receptor tyrosine kinases and the RAF cascade are important components of the treatment targets for HCC. We'd like to focus a little bit more specifically on some of the trials and agents that have made it to the clinic. So I'm going to turn things over to Dr. Stein to lead the way on immune checkpoint inhibitors for HCC.
So here's the first line study of atezolizumab plus bevacizumab. And the initial data came from a phase 1 study looking at the combination. This was a multi-arm study, and HCC was one of the arms. And in that study, there was an impressive 36% response rate. Based on this data, a randomized study was conducted. This is the IMbrave 150 study, where patients were randomized 2-to-1 to the combination of atezolizumab and bevacizumab versus sorafenib. And there were co-primary endpoints of this study of overall survival and progression-free survival. In addition, patients were stratified based on location, ECOG performance status, whether they had macrovascular invasion and or extrahepatic spread, and by AFP levels. And here we see the overall survival, which increased from 13.4 months with sorafenib to an impressive 19.2 months. In addition, when we look at the response rates, we see that about a 30% response rate by RECIST 1.1 criteria that was slightly higher by mRECIST criteria. About 8% of patients had a complete response, and another 22% of patients had a partial response, and another 44% of patients had stable disease. So that led to an impressive disease control rate of 74%. And the median duration of response was 18.1 months. So this was data that we had not previously seen in HCC. When we looked at the safety, we knew what the common side effects were of sorafenib, including diarrhea and palmar-plantar dyserythesa, which we saw at much lower rates with the atezo and bev combination. There was about equal incidence of hypertension, which we knew happened with sorafenib and could occur with bevacizumab, which was able to be treated. One of the side effects that was especially looked at on this study was the risk of bleeding. All patients on this study had to have an EGD within 6 months of initiating treatment to evaluate for varices, and those needed to be treated according to local standard of care. So it was not an exclusion criteria, but it was required to have the testing done, and they were allowed to have treatment and still go on study. The rate of upper GI bleeding was 4.5% on the sorafenib arm and 7% on the atezo and bev arm. To update the case, our patient received atezolizumab and bevacizumab as initial systemic therapy. After 3 cycles of therapy, she had restaging imaging, and the MRI showed a 50% reduction in tumor volume with an AFP decrease to 150, and her abdominal pain had greatly improved. Her hypertension did worsen on bevacizumab and required uptitration on her antihypertensive regimen, but otherwise she did tolerate therapy well. And a year later, she continued on therapy with excellent disease control. So, Dr. Burgoyne, what would you do differently if the case changed to the same patient who had had a recent esophageal variceal bleed, let's say 2 months prior to diagnosis?
It's a really important question, Dr. Stein. And as you just very carefully summarized for us from the IMbrave 150 data, it was mandatory that all patients that participated in that study had had recent EGD for assessment of their bleeding risk from esophageal varices, and patients that had had recent bleeds were indeed excluded from that study. And, one of the main concerns is, giving a patient a monoclonal antibody that increases their bleeding risk. If they're to develop another bleeding event on therapy, we really would consider that to be a safety issue that would be a non-starter for us to consider bevacizumab for a patient in that situation. So we really do need different options for such patients that are high bleeding risk. And I think that's what we're going to move into next for our subsequent topic of discussion. So let's talk about potentially VEGF sparing treatment strategies. And really the newest kid on the block is this concept of using dual immune checkpoint blockade with the STRIDE regimen in HCC. So STRIDE is an acronym for single tremelimumab, regular interval durvalumab. So these are targeting CTLA-4 and PD-L1 in combination. And the landmark study that led to this data being assessed and the subsequent FDA approval of this combination was Himalaya. This was a very large phase 3 randomized multi-center open label trial of 1,324 patients at 190 centers across 16 countries. And the treatment population had some overlap and similarities to the IMbrave 150 treatment population. So again, these were patients who had advanced HCC that were treatment naive with no prior systemic therapy. All patients did have to have good liver function, well-compensated Child-Pugh-A disease, performance status less than or equal to 1. A few key differences from IMbrave 150 is that an upper endoscopy was not required for participation in this study, and patients with main portal vein thrombosis were also not allowed to participate. They were excluded from the study. So patients were randomized and stratified according to the presence of hepatitis B, hepatitis C, or other causes of their liver disease. Patients were stratified based upon performance status, and patients were stratified based upon the presence or absence of macrovascular invasion. The study design for this study was a little bit complicated. It evolved after there was a companion phase 2 study showing that this dosing strategy using a single priming dose of tremelimumab of 300 milligrams times 1, only given with the first cycle, in combination with durvalumab given continuously every 4 weeks, was the optimal checkpoint blockade strategy. And the final analysis was based upon this treatment arm in comparison to durvalumab monotherapy, in comparison to sorafenib as prior standard of care. And the key endpoints for this study was a primary endpoint looking at overall survival. Key secondary endpoints were looking at the overall survival of durvalumab monotherapy versus sorafenib. And then other secondary endpoints were progression-free survival, response rate, and duration of response. So the kind of top line data here is that Himalaya did meet its primary endpoint of improving overall survival when we compare the use of the STRIDE regimen to prior standard of care therapy with sorafenib. You can see here from this Kaplan-Meier curve that the median overall survival with STRIDE was 16.4 months versus 13.8 months with sorafenib, with a hazard ratio of 0.78. And this slide here in particular carries out those Kaplan-Meier curves from 18 months to 24 months to 36 months. And that was one of the other key achievements of this Himalaya study, having this long-term overall survival data showing ongoing improvement in survival at 3 years. So as I mentioned, one of the other endpoints of the study was looking at durvalumab monotherapy versus sorafenib. This met the statistical significance for non-inferiority. So numerically, the median overall survival was 16.6 months for durvalumab monotherapy versus 13.8 months for sorafenib. And what's unique about this data is, although, as Dr. Stein mentioned, there had been prior studies looking at nivolumab and pembrolizumab in the frontline setting, this is the largest data set to date to show at least a non-inferiority of immunotherapy in comparison to sorafenib in the frontline setting. So let's talk about response rates. So the objective response rate to STRIDE was 20% versus 17% for durvalumab monotherapy versus 5% for sorafenib. We did see complete responses in a subset of patients with STRIDE, 3%, versus 1.5% with durvalumab monotherapy versus 0 with the sorafenib arm. And in terms of stabilization of disease and disease control, about 40% of patients in the STRIDE treatment arm did achieve stable disease with a disease control rate of 60% versus a similar disease control rate of 60% for sorafenib. The differences here, though, are the median duration of response being 22 months for STRIDE versus 16 for durvalumab versus 18.4 for sorafenib. So let's talk about safety. Again, as we're balancing these evolving and new treatment options for our HCC patients who aren't all the same, and in particular for this case where we're considering someone that was at higher bleeding risk, you can see here that the rates of hemorrhage were within acceptable ranges that we would expect for this population and relatively well balanced across the treatment arms. So what's really exciting about this new FDA approval of STRIDE is it's a new frontline option for advanced HCC patients that have a higher risk of bleeding with this VEGF-sparing regimen. I think most everyone is familiar with the concept of immune-related adverse events. This has really changed how we think about toxicity management for our cancer patients. We know from many other studies of immunotherapy, as well as our routine clinical practice at this point, that this upregulation of the immune system as part of the mechanism of action of checkpoint blockade also comes with a risk of immune-related adverse events, which can really span across all organ systems and have a somewhat unpredictable course. And when we were first starting to use immunotherapy in the HCC and liver disease population, we did have some concerns that, perhaps hepatitis, immune-related hepatitis, would be something that would be limiting. That hasn't really shown to be the case, although we certainly do see immune-related adverse events in our HCC patients that are treated with immunotherapy. One of the concerns about Himalaya was that the use of dual immune checkpoint blockade in comparison to other regimens that we use for HCC and other tumor types, such as ipilimumab plus nivolumab, that we would see very high rates of immune-related toxicities that would be prohibitive to therapy. We certainly did see immune-related toxicities, up to 20% of patients requiring high-dose steroids in the STRIDE arm, grade 3 to 4 events in 12.6% of patients. But generally speaking, you can see here with the immune toxicities that are listed, these are within the spectrum of what we have become accustomed to in the immuno-oncology era. And if we compare this data to Checkmate 040, which is the study of ipilimumab plus nivolumab, that had 53% grade 3 treatment-related adverse events. So, with the caveats of a cross-trial comparison, it does appear, at least from Himalaya, that the STRIDE regimen has a somewhat improved and acceptable safety profile. Let's flip this case on its head again and imagine that instead of the baseline characteristics that we presented thus far, what if our patient now has a history of active ulcerative colitis and is requiring immunosuppression for the control of that disease? Dr. Stein, does that change our options for systemic therapy?
It really does. Those patients were excluded from both of the studies that we just reviewed, the STRIDE regimen and the atezo-bev study. There is just too much risk there of adverse events with more severe immune reactions, so that we wouldn't really think about putting those patients on a regimen with immune therapy at this time. Similar to another group of patients that we see not very commonly, right? But sometimes in this HCC population are patients who had prior transplant. And that's another group that we really would not think about putting on immune therapy. There are some exceptions of autoimmune disorder. So those patients who have hypothyroidism and are already on thyroid replacement therapy, patients with controlled type 1 diabetes, or some skin disorders where it takes up less than 10% of their body surface area and could be controlled with low potency topical corticosteroids. So that group of patients have been successfully treated with immune therapy in different cancer groups, and we have confidence in treating those. But outside of that, I wouldn't really think about, offering these treatments.
I think that's an excellent summary. And I would pose a follow-up question for these patients. What other options do we have if immunotherapy is not on the table?
So let's go to the next section and we could talk about the tyrosine kinase inhibitors. As we mentioned before, sorafenib used to be the only option, and we've largely moved first-line therapy to these combination regimens. We do still have the option of using multiple tyrosine kinase inhibitors. So we have the data for sorafenib in the first line from the original SHARP study, and then lenvatinib from the REFLECT study. And then we also have second line data of regorafenib and cabozantinib in studies that looked at patients post sorafenib treatment. These tyrosine kinase inhibitors are kind of dirty inhibitors, meaning that they don't just target one particular target, right? They target multiple ones. So you can see that VEGF has commonality between all four of these. And then other ones that are in some of them are the platelet-derived growth factor receptor, KIT, the fibroblast growth factor receptor, RAF, AXL, CMET. So there is some overlap between them, and then there are some differences. And I wouldn't say that we necessarily know for each one what the main target is that shows us, the efficacy of these drugs. But we do know, right, from these studies that there is efficacy of each one. So going back to sorafenib, from the SHARP study and Asia Pacific study, these were compared to patients were randomized to placebo or the drug in the first line. And the median overall survival in those sorafenib studies was in SHARP study 7.9 months versus 10.7 in the sorafenib arm, and in Asia Pacific study, which was primarily a hepatitis B population of patients, the median overall survival improved from 4.2 months to 6.5. Then years later, we had the lenvatinib REFLECT study that looked at patients in the first line. This was a non-inferiority study to sorafenib. So while the median overall survival was not improved, we did see better tolerability and a higher response rate from 7% to 19%. And so based on the adverse events and the response rate, lenvatinib has largely replaced sorafenib as use for a first TKI. Then we have the RESOURCE study that looked at regorafenib in the second line. This study, patients were randomized to placebo or regorafenib, and we saw an improvement in median overall survival from 7.8 months to 10.6. And very similar data from the Celestial study of cabozantinib. Patients were also randomized to placebo versus the TKI. And the overall survival improved from 8 months to 10.2 months. Because they don't all target the same receptors, we do see some differences in toxicity, but overall, there's a lot of overlap. So we see fatigue, anorexia, weight loss. There can be alopecia, nausea, diarrhea, abdominal pain, hand-foot syndrome, rash, hypertension, probably from the VEGF component, proteinuria. Sometimes patients have voice changes where they feel that, especially by the end of the day, they have decreased ability to speak in a normal volume. Hypothyroidism also, we routinely check thyroid function similarly to following it in patients on immune therapy. And so, there are some differences between them. There was less hand-foot syndrome on lenvatinib versus sorafenib. And so because of that, it seemed like overall it was a better tolerated treatment. When we look at that data where patients were receiving first-line therapy with a TKI, and then the second-line therapy was for those patients who had progressed on initial TKI, it becomes less clear what to do when we're starting patients with atezolizumab and bevacizumab or durvalumab and tremelimumab. And I would say this is one of the most common questions that comes up of how do we sequence therapy at this point. So we can think about TKIs first line for patients who are not candidates for immune therapy first line, as we were just talking about. But I think also people want to know, if we start with immune therapy combination, right, how do we sequence in after that? What do we go to second line, and which TKIs are favored? So Dr. Burgoyne, do you want to give us your thoughts about options at disease progression?
Sure. And, as you mentioned, Dr. Stein, this is a very common and complex question, because I think at the end of the day, we don't have great data to tell us what to do in this situation. So essentially, the majority of second and beyond line data that we have is for patients that received sorafenib in the frontline setting. And as Dr. Stein just educated us, we really don't use that routinely in the clinic anymore. So most patients are not falling into those clinical trial categories. So really, atezolizumab plus bevacizumab has become our workhorse standard of care regimen for HCC. So for patients that are good candidates at initial presentation, that's what we're thinking about for them. So at disease progression on atezolizumab plus bevacizumab, we're need to start thinking about changing mechanism of action in some way. So for some of my patients that are fit and robust and would be good candidates for tyrosine kinase inhibitors, I would think about using lenvatinib or cabozantinib in the second line setting. We do have data supporting the use of dual immune checkpoint blockade in the second line as well, with ipilimumab plus nivolumab. So, does changing VEGF for CTLA-4 lead to a resensitization of disease? I think that remains a question that we're continuing to ask in clinical trials, but that would potentially be an option for disease progression after atezolizumab plus bevacizumab for me. Do you have comments on your practice, Dr. Stein, in that setting?
Yeah, I think that was very interesting to bring up the ipi-nivo data in second line. And I think that's a very provocative question of, would you think about continuing immune therapy or adding in the CTLA-4 antibody later? And I think we really don't know the answer to that yet. But, I know sometimes when someone has been on immune therapy for a long time and has had a good response, there is that thought of whether you can rescue a patient again. And I really look forward to seeing data on that to really, let us know whether we should be offering that option to patients or moving to a TKI. But I think, for the most part, patients are getting TKIs in second line. Usually we restart with lenvatinib and then move through. I think what we're seeing more and more of is, as we are able to maintain patients' liver function and quality of life on these first line regimens, more patients are eligible, not just for second line therapy, but sometimes third line and fourth line therapy, and beyond. So I think it's so important for us to keep thinking about clinical trial enrollment, to answer these sequencing questions, and continue to collect that important data. And it's nice to see that so many patients are going on multiple lines of therapy now.
Do your thoughts change at all in this new era of post-STRIDE? I know we've all just been starting to use STRIDE for the past several months, but still thinking lenvatinib kind of as your workhorse in the second line setting for those patients, or any other thoughts?
I mean, it's so early. We're not going to go back and redo all of these studies, in subsequent lines of therapy based on what each patient received first line. So I think we'll be left with some studies, but a lot of real world data, and clinical experience. For now, I think I would be moving to a TKI, but if there's data to change that, I would be happy to change practice if we see that there's really a benefit of alternative options.
And I think it's very important that we're having these conversations and that we have these opportunities to talk as a group about what the best treatment options for our patients are. And I think that's a good segue into the use of multidisciplinary care for our HCC patients. Dr. Stein and I can talk as medical oncology colleagues, but also include our colleagues from all the relevant disciplines within HCC care. So that involves diagnostic radiologists, that involves pathologists, that involves hepatologists, that involves surgeons and transplant surgeons, that involves interventional radiologists, and then a large number of ancillary staff and supportive staff as well. So nutritionists, cancer support groups, well-trained oncology nurses, palliative care specialists, research coordinators. And it's really this opportunity for us to work together in groups, both in tumor boards, as well as multidisciplinary conferences and networks, both at institutions and across institutions, that we're able to, take the best care of our patients. And interestingly, but not really that surprisingly, there's been a number of studies demonstrating that the use of multidisciplinary care for HCC actually improves clinical outcomes. And you can see here from the data shown on this slide, those outcomes include the increase in HCC treatment receipt, improved survival, improved early detection, improved rates of curative treatment, time to treatment. And these are obviously key outcomes for our patients. So I can't really emphasize enough how important this is for our patients, and as clinicians, how important it is for us to have that support to work together to take care of our patients.
I agree. And not only is it very important at the initial diagnosis to think about what the best treatment option is for each patient, but as their treatment evolves and we are involved in more studies of neoadjuvant therapy, adjuvant therapy, combination therapy of systemic therapy and local therapy, right? As we kind of get more active regimens and think about move them into different settings, the conversation really changes. Also, some patients have such a good response on initial therapy that it makes sense to go back and potentially think about resection or local therapy again. So it's been so rewarding, and interesting to work with these large multidisciplinary groups for our patients.
Well, thank you all for your attention today. Just to give some summary points here, I hope that Dr. Stein and I have convinced you that the armamentarium of systemic therapy options has vastly increased over the past several years. We now have 4 FDA-approved first-line agents, atezo plus bev, durva plus tremi, lenvatinib, and sorafenib, and 6 second-line agents, regorafenib, cabozantinib, nivolumab, pembrolizumab, ipi-nivo, and ramucirumab. And as Dr. Stein just mentioned, we're really thinking a lot about combination strategies, both of systemic therapies as well as moving systemic therapy in different therapy settings, including in combination with local regional therapy. These combination strategies appear to be improving efficacy and are becoming standard of care. We really don't know how to sequence all of these medications that we have available to us now. And it's critical that, we continue to move forward with clinical trials and biomarker-driven discovery to improve patient responses and outcomes. Thank you all for your attention today. We really appreciate your engagement in this important discussion topic on management of patients with hepatocellular carcinoma.